Hello, everybody. My name's Kenny Bloxham, and I'm one of the healthcare leaders here at Webex by Cisco. Delighted that you've agreed to join our webinar today, where Mid and South Essex NHS Foundation Trust are going to talk about how they've reduced DNAs, increased capacity through connected healthcare journeys, all powered by AI. Next slide, please. Before we get into the webinar, I want to welcome some special guests. So first of all, Tony Young is a consultant urological surgeon and associate medical director from MSc. Welcome, Tony. We then have Erica White is our program director for MSc. We have Ben Beldelder, co-founder and CEO of Deep Medical, one of our key ecosystem partners. And then finally, we have our very own Mark Broughton. So we're going to go from back to front. So Mark's going to kick us off. We're then going to move to Ben, and then we'll have the bulk of the session, bulk of the webinar run by Erica and Tony. Just a little bit of housekeeping. You can't come off mute, first of all. And secondly, if you do have any questions, please put them in the chat. And when we get to the end of the webinar, we'll spend 5-10 minutes just answering some of those. If we don't get through all the questions, we will obviously ensure that we follow up and give you the appropriate answers. Okay. Enjoy the next 40 minutes. It's really compelling, really insightful. And over to you now, Mark.
Thanks, Kenny. So I'm just going to give a little bit of context and background in terms of the technologies that have brought this use case to life. Ultimately, we're all service users, and life happens. We have questions, we need support, we need to change or cancel an appointment, and increasingly we expect that care providers engage with us in the same way that other industries do and meet us where we are. So to sort of tackle that, first, we need to be delivering proactive communications. Engage with patients to help them manage their care pathway with intelligent, relevant and timely communications. Secondly, provide fast, easy, intuitive and simple to use self-service options. And finally, when the need arises to escalate to a human, ensure that engagement is empathetic, it's personalised and it's solution orientated. All of this is to be delivered across an increasingly complex communication environment. With technologies and communications evolving at a pace, particularly in healthcare, it's often not in a very joined up way, and the increased use cases and touch points across the patient journey, across an increasing range of digital services, from PEPs to the NHS app, with phone, video and various different messaging channels, starts to increase that complexity. With this expansion in technology and patient expectations comes the need for unification. So this is our view of the patient journey. There are extensive opportunities to engage patients in a proactive self-service manner. From that very start point of that patient journey, the referral, right through to post-discharge support, outreach. I know that all of you that have joined us today can identify numerous touch points on screen where you have some form of engagement and potentially multiple solutions that are supporting them and delivering across those touch points. The important takeaway here is that we have new ways of engaging patients that are unified. They're more efficient, more empathetic and personalised, which ultimately delivers on better healthcare outcomes for patients and providers. So before we bring this to life for the patient journey, I just want to set the scene quickly on the technology that will be powering the experience. So how do we deliver this connected patient experience? We have a core focus on business and patient outcomes. We do this with our unified portfolio across Webex that can deliver an integrated patient experience across 3 core workloads: proactive journeys, AI agents, and human agents. So that proactive journey is all about anticipating patient needs. Give patients the information that they need before they ask for it. If someone gets in touch, it's often because we've forgotten to tell them something, or we haven't delivered it in a timely fashion, or an easy to access mechanism. Then provide an AI front door. That leads to effective resolutions, whether that's as a front of house FAQ service to help with navigating the huge amount of information that can be found on the Trust website, or if it's a more scripted, task-orientated bot to support self-service tasks such as rebooking or rescheduling an appointment. And then when needed, escalate through to the expert, to a human agent empowered with AI to better interact with patients and deliver on outcomes. And all of this can be fully delivered across the Webex portfolio. So we believe that if harnessed correctly, AI can turn a frustrating experience into an exceptional one. The recent technology advances in generative AI and large language models were the missing link. LLMs fix the problems with being understood. Generative AI, along with LLMs, make conversations more natural and human-like. And ultimately, we believe that we've got the technologies to create a golden age of patient experience. So with that in mind, I'd like to introduce Ben Delder, co-founder and CEO of Deep Medical, to explain how they've applied AI to better support both patients and staff in maximising attendance and clinic utilisation.
Thanks, Mark. Great. So nice to meet everyone on the call today. So what are we doing at Deep Medical? So our key focus is about how can we expand capacity in healthcare powered by AI. If you could click the next slide for me, Mark. I think it's important that we firstly look at what is the problem that we're trying to solve. Well, currently there's about 5.9 million patients waiting for a hospital appointment. About 8 million DNAs across secondary care, and about 4 million short notice cancellations, which just don't go filled. And finally, 10 years of life expectancy difference between the richest and poorest 20%. That makes us the worst from a health inequalities perspective across Europe. And these are really important stats because, as we'll go on to talk about. Mark, could you click the next slide for us, please?
Yeah.
So what are we trying to do? Well, to put it in a really simple sentence, the goal of the AI tools are there to try and change patient behavior from no-shows to attend, and when we can't, use that slot for another patient. Next slide. So how do we do that? Pretty early on, we actually got published in Nature Journal back in 2017 about using machine learning models to predict patients' DNA. And we decided early on to actually, how can we build ethical AI? And what that means is not just from the data set that we need, but all the way through to the applications that we build on top of that. So we stripped the patient data. We removed any sort of special category health information data from there. And what we did was we started to group the data across sort of 3 buckets. The first, which is around the patient. So what are their social determinants of care? What are their historical behaviors? What are their travel and transport links likely to that they're going to take? And what's the weather like? And then the other 2 sides are much more focused on process mining of what's going on at the hospital. How many messages are you sending out? When are you sending those messages? What's the number of cancellations that you've had at that appointment? How far do you book appointments? And finally, who are the clinicians and how are they behaving? And what are the clinic templates that they're actually seeing compared to their colleagues? And I suppose it's never one of these factors that puts a patient at risk. It's always how all of these factors are interplaying with each other, which means that we can get really accurate and not just changing patient behavior, but also predicting it and booking those extra slots as well. Next slide. And why is that important? Well, as I said, 10 years of life expectancy difference between the richest and poorest 20%. And when you look at those same population groups, you see that if they don't get to their hospital appointments, they have worse outcomes. Against every single one of NHS England's core 20+5 areas, clinical areas, you see significant risk factors in those patients that DNA. Next slide. And what we're also able to see is the index of multiple deprivation, specifically within the most deprived population groups, as you're seeing here in the purple bars, significant risk factors across all age demographics for patients that miss those appointments. But it's not just important to think about it from a quantitative perspective. I think what you need to do as well as part of building ethical AI solutions is also speak to people and hear what are they saying. And so pretty early on with Mid and South Essex, we spoke to over 5,000 patients. You could click the next slide. We heard stories like Khadija, who's being sent text messages and letters to her ophthalmology appointments with visual impairments. We heard stories like Jim, if you click the next slide for us, Nigel, who's having problems getting through to transport lines, and also a myriad of other issues like I can't afford to take time off work, I can't afford to take the journey in, I've got carer commitments, you sent me 3 letters and I don't understand what's going through. And so what we wanted to do was take the learnings that we had and start to think, how can we build technology that personalizes outreach here? And that's really what we brought together with Webex. What we started to do there was start to think about how do those risks of missed appointments help us stratify and personalize the channel that patients should be communicated to, the number of messages patients should get, and the content of what we want to be sending to them. And against each one of those interactions, what we're trying to do is drive up engagement. What are the patients doing from a cancellation and reschedule request perspective? If you click on the next slide, that's then feeding back to our main product, which is really there to then think about how do we change a clinic template from a static function to something that's much more dynamic with safety functions. And what we've built here together is a solution that allows hospitals to get control over that, forecast where those gaps are going to be, set safety metrics like capacity caps, so how many more do we want to book in ever, and also think about how targeted we want to be in order to unlock those additional appointments. And finally, as we start to make that transformation through to standardization, how do we start to visualize what's going on at a clinic template level so that we can hit those GIRF targets and ensure that all consultants are in all clinics are behaving to the same level? Next slide. And why is that important? Well, currently, from what our evidence has shown across Mid and South Essex, is that we can continue nationally and really think about how we can unlock 4.4 million additional appointments using these sort of two approaches through targeted reminders and dynamic scheduling. What does that mean from an envelope spend perspective? As we know, there are significant financial pressures in the NHS. And what we found through our investigations is that about 2% of capacity is currently being spent on waiting list initiatives, which accounts for about £345 million of cash. But importantly, at full scale, how else can we also hit those RTT targets? And what we've seen is that from our modeling is that at full scale against those two capacity goals, we can hit those sort of 65% RTT targets within a 6-month period of time. Next slide. So that's really keen to hear from us, but I think the really great thing is to hear from Mid and South Essex, who we wouldn't be here without. And so I'll pass on to Erica, but equally, if there's any sort of people that want to reach out and speak to us, then please, well, we've got your contact details equally, those are ours. So thank you.
Thanks, Ben. So on our outpatient transformation program, Tony and I have been collaborating with both operational and clinical colleagues over the last couple of years to consider our opportunities to adopt and implement digital technologies and approaches that can help us to deliver outpatient care in an innovative, efficient, and patient-centric way. Next slide, please. In 2023, our trust lost around 152,000 outpatient appointments to DNAs and last-minute cancellations, which, as you can see there, equated to around about 28 million of unused capacity. And we knew that tackling this waste was essential to enabling our clinical services to see patients sooner. Next slide. Our goals aren't unexpected. We wanted to support our patients to attend their appointments. We wanted to reduce the time our residents wait for elective care. We wanted to reduce waste and improve our productivity, and we wanted to address inequalities. And as a trust, we set a target of reducing the DNA rate to 6% by March 2025, with a further reduction to 4% by March 2026. Next slide. We have a track record of collaborating with early stage innovators to test, evaluate, and enhance their solutions in the real world setting of our 3 hospitals. And Deep Medical's innovation aligned with our ambitions in the outpatient space, and we've now been collaborating with Deep Medical for around 2 years. We worked with them to enhance their advanced AI algorithms, which helped us to understand the various factors that contribute to why our patients miss their outpatient appointments or cancel them at short notice. The AI tool then helped us to accurately predict patients who will potentially DNA and the reasons why. A pilot was undertaken in 2023 across 3 of our specialties, urology, dermatology, and pain, to gather learning. And we took that learning to enhance the tool and the approach. To do this, Deep Medical took 12 years of our attendance data, and they combined that, as they said, with over 200 other data points to inform the AI forecast. And we used the insights produced by Deep Medical to undertake proactive outreach calls to those patients who were identified as being at high risk of DNA or short notice cancellation, and to understand if there was anything we could do to support them to attend their appointment. And from that pilot, we learned that patients that don't pick up the phone probably aren't going to show up for their appointment. And as Ben touched on, there are a variety of reasons why patients DNA, and many of these are factors that contribute to health inequalities. The proactive patient phone calls undertaken during the pilot, whilst they served a purpose, required significant admin support, and scalability was impacted by resource constraints. We also found our clinic code data was messy, with dormant clinics and not all clinics being patient-facing. And we knew that clinical and operational leadership was going to be critical to achieving full benefit from the Deep Medical solution. Next slide, please. So you can see from our pilot KPIs that the impact was obvious. DNAs were prevented through proactive outreach, around about a 50% reduction. Improved clinic utilisation through filled last-minute cancellation slots. The AI forecasts of non-attendance were impressive. They were 96% accurate during the pilot. And targeted backup booking recommendations were made, but unfortunately not followed through. And as a trust, we knew that we wanted to take this further. Next slide, please. So based on the success of the pilot and a successful bid application, we were awarded funding from the Department of Health to support a full implementation. We took the time to assess our lessons learned and to plan how we could best maximise the funding opportunity. And it probably goes without saying that the AI only does part of the job, and to realise any benefit from the AI required changes to our ways of working. So calling patients was a heavy admin overhead. We knew we needed a mechanism which was scalable and not impacted by our resource constraints. And we had recently piloted two-way SMS reminders with our partner Cisco Webex at our Broomfield site, and knew that we wanted to roll this out across our sites at Basildon and Southend, so that our patients had an easier way to contact the trust and to also let us know if they needed to rebook or cancel their appointment. And based on the evidence from the Deep Medical pilot, where patients who didn't answer the phone were less likely to attend their appointments, we asked Deep Medical to partner with our SMS provider, Webex Connect. And that enabled an integration that would allow Deep Medical to manage our SMS message flows, which would essentially enable us to send targeted messages at varying frequencies to elicit the best outcomes to support our patients in attending their appointment. And in addition, the responses coming back from text messages to confirm their attendance or request a rebook or cancel would enhance the machine learning further. Secondly, we knew we needed a standardized organizational approach to support what we call dynamic scheduling or targeted backup booking, to proactively mitigate the impact of patients who are highly unlikely to attend their appointment. In the pilot, dermatology experienced a 30% reduction in DNA through the use of targeted proactive outreach. But if we had utilised backup booking in addition to the proactive outreach, in line with the recommendations from Deep Medical, we would have seen a more substantial impact on clinic utilisation. And we knew to go forward, we needed a mandate to implement targeted dynamic scheduling. We secured this from our Clinical Design Authority in March 2024. We worked closely with our information governance lead throughout the pilot and the wider project, and this has been critical to our success in onboarding new AI technology. We co-produced the text message reminders with our booking teams, taking learnings from the two-way SMS pilot and the existing one-way reminder service. And a significant exercise was undertaken with our operational teams to validate our clinic codes and develop defined criteria. And that was agreed with our Clinical Design Authority to determine which clinics should be in scope for SMS reminders and therefore AI forecasting of non-attendance. And then as a group, we agreed a logical phased implementation approach. Next slide, please. So we went live with two-way SMS across all of our specialties at all of our sites on the 31st of July last year. And for the first month, the AI model was learning. We used different messaging flows to gauge the engagement levels. And at the same time, we deployed DM schedules, which is our outpatient tool that we use to allow our booking teams to manage the patient responses coming in from two-way SMS and to enable them to find the next available clinic slots. Something that previously took significant capacity was now available at the touch of a button. And I can't underestimate the impact that that's had on the booking teams to date. In month 2, Deep Medical commenced making their DNA forecast for 10 specialties that we selected as our phase 1 deployment cohort, and that was based on our highest DNA rates across the trust. And during this time, no proactive intervention was undertaken except for the bespoke reminders. During that time, we were able to compare the AI forecast with actual attendance data, and we continued to see a high level of accuracy experienced during the pilot. We were also able to demonstrate the increased patient engagement rates between the cohort 1 specialties that were using the bespoke messaging flows and the other specialties who continued to receive our standard SMS message with no bespoke adjustments, which demonstrated the impact that we could experience if we were using Deep Medical across the organisation. In October, we felt comfortable with the evidence generated to move all specialties to the bespoke messaging flows and to commence AI forecasting, to gather evidence of the forecast non-attendance versus actual attendance. We then kicked off meetings with each of our cohort 1 specialties, clinical and operational leads, to share the data to date and to discuss phased implementation of targeted backup booking. As expected, there was nervousness from our clinical colleagues about the potential for patients co-arriving when the forecast DNAs or short notice cancellations don't materialise. And then the patient who has backed up booked also attends. But the provision of the evidence from the first couple of months of forecast versus actuals, along with some very enthusiastic clinical leads, was sufficient to get an agreement to progress. So what did that actually mean? It meant that if the AI predicted that someone was highly unlikely to attend their appointment, and then they also didn't respond to the text reminders being sent, we were then able to take further proactive action by placing a backup booking in the clinic. We don't cancel any patients, we just put an additional booking into the clinic. And we tend to do that at the beginning of a clinic to prevent any potential overruns. It's also important to emphasize it's not a blanket overbooking approach, it is targeted based on not only the AI prediction, but also the lack of patient response to the SMS reminders that are sent. At all steps in this journey, we have been cautious and have looked to mitigate risk wherever we can. The backup booking for the first 10 specialties in cohort 1 was phased over a 6-month period. Strict criteria was put in place to identify the clinics that would be in scope for backup booking and to reduce the risk of potential patient co-arrival. And due to the success seen during this period, we agreed to roll out targeted backup booking across all in-scope clinics, and that went live last month. And at this point, I just want to stop for a second and say a big thank you to our partners at Deep Medical and Cisco Webex, but also a special shout out to our internal teams like Healthcare Analytics, Information Governance, our digital team, and our outpatient referral and communication team. Given the scale of this implementation, organisational-wide, it has been relatively smooth. Not only that, but the agility of our partners to respond to feedback received from users has been incredible, and we are always looking for ways to improve the usability and usefulness of this technology. And collaboration has really been central to our success thus far, so a big thank you. Next slide. So as I touched on earlier, the technology is an enabler, and business transformation, including process and culture changes required to deliver any successful digital implementation. So on this slide, you see an overview of some of those things that we did. A comprehensive comms and engagement strategy was key. We attended all the forums across our organisation, including trust leadership meetings, clinical design authority, technical design authority, quality assurance group, digital champions, innovation working group, clinical strategy group, clinical director touch points, operational director touch points, and all of our staff briefings. We wanted everyone to be engaged with what we were doing, and raising awareness of this and where possible co-producing our approach to this initiative were critical. And what that really enabled us to do was to head off any potential concerns and deal with those before we actually went live. We also created SOTs and updated our policies. We collaborated with Deep Medical to develop user guides and deliver online training, and worked with them to create insights and reporting dashboards. And we also provided ongoing email support for any issues arising. Next slide. So impact. Deep Medical's suite of tools integrated with Cisco Webex capability have played and will continue to play a crucial role in our outpatient transformation strategy. Collaboration, as I mentioned, has been central to this project's success, and with continuous input from multiple teams across the trust and our external partners. This engagement has been instrumental in achieving what you can see, tangible results. And since October, we've seen a downwards trend in our DNA rates between we're around about 6%. And then what we saw last month, 5.8%, which was down from an average of around 8.63 24 months ago. However, we do believe that further improvement is possible as we work towards reducing our DNA rate further to 4% or less. And as you can see to date, the benefits combined from the pilot, and since we went live across the organisation, we have prevented wasted resource to the value of almost 2.5 million. And that means we are supporting our patients to attend their outpatient appointments, reducing health inequalities, improving equity of access, and ensuring that our patients are seen sooner. The potential of these tools to drive productivity is significant, and we are excited about the 3-year program of work that we've just agreed and designed to support our trust selective recovery efforts. You've heard a lot from me now, and I'm going to hand over to my colleague Tony to share a clinical perspective on the project to date.
Excellent, thank you, Erica. And unless you've got any more slides, we can take them down so people can see the real human being. Oh, there are more. We'll just take the slides down, shall we? Hello. So I'm Tony Young. I am still a practicing consultant surgeon in the NHS. Can we get rid of the slides completely and just have the gallery of people with us? I am Associate Medical Director across Mid and South Essex, responsible for innovation research, transformation, commercial procurement and digital. I'm the Chair and Director of Innovation and Entrepreneurship at Anglia Ruskin University, and I'm here in this rather dull-looking basement room at NHS England today because I'm the National Clinical Director for Innovation for the Health Service in England and have been for the last 11 years. What Ben didn't tell you is he's one of our NHS England clinical entrepreneurs and has been on our program, our corporate entrepreneurship program, nationally run and commissioned by NHS England to help take those frontline problems, those things that our staff have identified and are really good, and then putting it all together. And guess what? He's absolutely aced it over the last 4 years. Look at what you've just seen. Now, I'm not going to talk to you about that and the development of the company. I'm going to talk to you about the easiest bit of the transformation journey in healthcare, which is working with consultants. You all know it. They're the nicest people in the hospital. They're the people who step up and say, change, yeah, let's have more of it. I want everything. We want to embrace it. You know, I'm not being serious. That's the hardest thing, isn't it? What Erica has described sounds amazing. If you don't bring clinical colleagues with you, however amazing that is, it's never going to happen. Cisco could be amazing. Whoever your tech partner is could be amazing. Erica, well, she is amazing. I mean, look at how she has distilled the last 2 years into that kind of 10-minute in such a beautiful way, showing our amazing outcomes. Ben and his team at Deep Medical are amazing. That counts for nothing. If the consultants who are legally responsible for patient care dig their heels in and say, we ain't going to change. So medical leadership has been absolutely fundamental to getting this over the line. So as one of our medical directors at Mid and South Essex, as well as being a national leader at NHS England, I wanted to show this is really important. You know, I think we've heard, haven't we, 8% of people don't attend their appointments nationally. We're paid for them, and about 4% on top of that cancel at short notice. So that's 12% nationally. 12 million outpatient appointments per year are missed. We're paying for them. NHS England are paying for them. Your organisations are paying for those slots. We're paying for the clinicians. We're paying for the rooms they sit in. We're paying for the investigations that are not utilised as a result. So we've been making the case for the last few years that we should be doing something about this. We should be trying to identify and fill those slots. And we can't do it on the basis of airlines who overbook. Can you imagine if people turned up to the clinic, the vulnerable, the elderly, the frail, people with multiple comorbidities, and we said, sorry, the clinic's full. Can we pay you 50 quid and you can take the clinic tomorrow? We can't do that. That's what airlines do. That wouldn't be fair or equitable or right, or treating people as human beings. But we also have to respect that our workforce, particularly following the pandemic, feel overwhelmed. I feel totally different than before I did I've been a consultant for 17 years than before that. And we want the NHS to be the best place for our workforce to come and work, to do what they're so good at, which is caring for and treating our patients and doing that in a timely manner too. We don't want to overwhelm them or overburden them. And I think Erica said it, she put it very diplomatically. I thought she was going for a job in the Foreign Office for a minute. She was so diplomatic. She said there was some nervousness amongst clinicians. And I'm going, we all know what that means, doesn't there? You're overbooking my clinic. I'm not going to see the patients. You come and tell them. That's not what we were doing. When we really look at the figure and the data that's going on, our clinic utilization was well under. Our consultants' job plans say you will do this many clinics and you will see this many patients in each clinic. And because of non-attendance, and I think as you've heard from Ben and you've heard from Erica, it's not the patient's fault. It's very unusual that the key reason is that they forgot or something, a simple text message reminder can address that. There are complex reasons why people do not attend. And the work Deep Medical have been doing with us on health inequalities to help us identify, actually, is it fair? Is it right? Does an outpatient appointment feel like something that's personal, that has been tailored to you, or does it feel impersonal and unfair sometimes? I just got a letter in the post and that was it. I've got to take this time or I won't get seen. It's not right. We can do better. So we made the case with our clinicians, we made the case that actually the biggest improvement we can see for patient care is by seeing as many patients as we can in a timely way. We set up something called our Clinical Design Authority, led by one of our site medical directors at Mid and South Essex. We're 3 hospitals that have merged together over the last few years. We had clinical leads from each site come and join that Clinical Design Authority. And what we did was we reviewed everything that we wanted to do in outpatient transformation. And being led by Emma Gray, our site medical director at Southend. If someone wanted to give a challenge, Emma was going to look at them and say, that's fine, we'll take that challenge, but we're also going to hold to account by what we should be doing and you would expect a medical director to do. We had our board bought in, so we had the blessing and permission of our execs, but we needed to win the hearts and minds of consultants. Now, the great news is, as most of you know, most doctors go into medicine, or most clinicians, I should say, because, of course, lots of colleagues deliver this work across outpatients, not because they wanted to earn a fortune. They'd have gone and worked in the city and made meaningless difference to columns on numbers in spreadsheets and all that thing. They came here because they're passionate and committed and driven about transforming patient care. And they recognize that patients are coming to harm on the waiting list. They're waiting longer. Their disease is progressing. Their conditions are getting worse. And they all wanted to improve quality of care, but they also wanted to look after themselves. They didn't want to have an overwhelming workload that they couldn't get done in the day. And through the support of the Clinical Design Authority, and by having individual going clinician by clinician where we needed to, specialty by specialty, to talk to them, to explain this story about how together we could work together to support our workforce, to see more patients each year just by filling those unfilled slots so we could improve quality of care and patient outcomes and reduce our waiting lists. We managed to bring our clinicians on board, and Erica told you earlier, and it's unprecedented at the moment with a startup that's now scaling like Deep Medical. Mid and South Essex, in the current environment, just signed a 3-year contract with Deep Medical to roll this technology out across our whole healthcare system. I'm confident that we will create an extra 100,000 outpatient slots, appointments that are currently not being filled across our system, and that will help transform our waiting list, transform patient care, transform recovery of our system, improve productivity of what we're doing. It's like bingo, everything we wanted to do for helping improve the service that we as a trust in Mid and South Essex offer to our patients is going to be helped by this technology. So I'm convinced and persuaded by it. I thought it was wonderful when I first heard about this. Okay, what Ben didn't tell you was this came out of UCL, the computer science division at UCL. They were doing work on non-attendance at radiology appointments. So this technology and AI has advanced a lot in that time. So I think it's wonderful. We've managed to persuade our colleagues, our clinical colleagues, to accept it. There are still people who are worried and concerned, and we've put a number of policies and procedures in place about when we will put backup booking in, and we can answer to assuage any anxiety there might be. I'm going to end up with 20 patients in the clinic and I shouldn't. That's not going to happen, and we will address it and we record it. And if there's an extra attendance, we will give that patient back, that time slot back on another clinic. So we've got ways of mitigating all this. So it's not all done. We're rolling out across all specialties now. It's this next year is going to show us. The data looks amazing. Erica showed you we've already reduced our non-attendance rate by over 2%. That's going to decrease more and more in the coming years. If I had to pick one technology that could transform recovery for the National Health Service, the ability to fill non-attended slots, the technology that enables that will be one of the most transformative things we can do. I think clinicians, when they understand that, get behind it, but you need your execs, you need your medical leaders, you need that ability to have that conversation, you need a great startup, you need great technology to set it across your system, and you need a great team, a great digital team, a great management team that can help incorporate that into it. Anyway, Erica, I've probably overspoken. At that point, I'll shut up and hand back to you.
Thanks, Tony. And I think that's us. So I'm conscious that we haven't touched on what next steps look like for us. And that's because I think that's a very exciting future webinar. But that we have agreed, as mentioned, a 3-year program of work, which takes what we've already put in place and builds on it. That's through a variety of different ways. And I can see some of the questions in the chat, and actually some of those speak to some of the work that we have planned over the next 3 years. So back to you, Kelly. Do we want to go to the questions?
Yeah, first of all, excellent, Erica, excellent, Tony, Ben, great, great position in terms of what you've done there. So fantastic and very impassioned, Tony. Love the passion on it. It is about the patient at the end of the day, isn't it? Let's be perfectly honest. So let's go to the questions. So I've got a couple for yourself first, Ben. We'll try and get these through as quickly as possible. So when you say previous behaviour, are you looking at their previous attendance at hospital appointments across the trust or wider, or something else completely?
Yeah, that's a great question. So we look at a myriad of different types of things around behaviour. So behaviour might be around clinic behaviour, it might be around patient behaviour. Some of the things are around whether they've turned up or whether they've had a hospital cancellation before, or in fact how they're sort of interacting with the messaging as well. So yeah, we look at a wide variety of different types of behaviours.
Great. Okay. And how did access to patient data work for training purposes? Were there specific permissions, processes, governance you had to follow?
Yeah, so I mean, the NHS has got really clear principles as to how and how you should handle data, what type of data you need to go through, and what evidence you need to demonstrate. So obviously we have DTAC, which we can demonstrate all of those sort of governance processes. But importantly, the actual questions should be asking around what is the minimum viable data set that you should be asking for? And that was a real question that we asked ourselves early on. That's why we stripped the identifiable features and we removed any health data from the historical data set that we pull from. So what that means is it actually, from a regulatory perspective, it even sits outside of the remits of GDPR. So really low risk data, but importantly, really valuable for us to train on that local data as well, so that we can understand what are the local issues that are taking place. So not just from the data that you're looking for, it's also about making sure that it's a local model that understands the behaviours of patients in Essex versus a larger one.
Great. Thanks, Ben. And I'll ask you this question and then I'll dovetail then to Mark. Have you linked with any Epic sites as yet?
Well, that's why we have great colleagues and partners like Cisco. So Cisco are the main communications providers. I'll plug you guys now for the Epic sites in the UK. So certainly, you know, through that relationship, we're able to be able to sort of leverage on that.
Great. Ben, Mark, just come in there, just to maybe talk about a little bit about footprint across the Epic sites.
Yeah, sure. So as Ben mentioned there, we work with all the Epic customers in the UK, deploying proactive communication. So engagements with, you know, those sites are in early stages. So do we work with them on this particular model today? Is a no, but there is opportunity there for the future.
Great. We're halfway there, essentially. Right, okay, over to you, Erica. Did MSC work with Deep Medical and Webex Connect to find the business model that would be acceptable? For example, is it a monthly payment or based on certain percentage of savings generated? And you probably don't want to get into specifics, I would imagine, but I think, you know, it is it's a good question, I think.
It is. Again, I probably wouldn't want to go into kind of commercial details, but we do contract separately with Deep Medical and with Cisco Webex. So Cisco Webex are our patient engagement kind of provider, communication provider, and Deep Medical support us with the forecasting and managing of those workflows. And it's only through the funding that we received that enabled that kind of integration to happen. But it is based on services provided rather than kind of savings generated as such.
But I'm happy to add in here as well that you know, that sort of aspect of how can we help you guys get to that step of releasing cash, and how do we then create business models around that benefit the NHS and us together in that journey, is certainly something that we would be really excited to speak to FDs and the likes of it.
Yeah, Tony, did you want to come in?
Yeah, just a couple of things I should have said. And number one is the comment people will hear all the time if you're ever going in for a business case is cash out. Where am I taking cash out? Just tell me. That's the only language at the moment, those two words. And we were able to show with Deep Medical to our execs. And I mean, Erica looks, you know, fresh and all set for summer, but if you saw the late nights and hours of redrafting the business cases that Erica had to go through, making sure she'd met someone else's thing, and cash out. And what we've done by that, we've looked at our evening and weekend clinics where we were paying overtime, and we said, well, we can stop these because of the capacity we'll create with Deep Medical. And that was one of the key things that got us through our business case approval at Mid and South Essex. And the other slight declaration I should have made right at the beginning, so forgive me. So at NHS England, I'm also responsible for rewriting our national intellectual property guidelines, which are going to be coming out. I'm expecting us to publish them in the autumn, or still to be confirmed. Hopefully the long term, the 10-year plan will be published before that. We'll wait and see. But the in that, it's keen on how could we make a return. So one of the reasons I'm here today on behalf of Mid and South Essex, for every contract we're a you know, exemplar site for, the Deep Medical goes, Mid and South Essex will make a small little royalty return because we've helped co-develop with them on this. And that's what I have loved about this. It's about the NHS putting some effort in, helping develop things, and also make a return on that for us to help reinvest in improving services for our population. So we do have a vested interest, but it's on behalf of the NHS, and I quite like that.
Great, thanks, Tony. We've got one from Jane to yourself, Erica. We experienced circa 3% cancellations with less than 24 hours notice, making backfill difficult. Do you have backup booking in place for this in addition to the DNA forecast?
So the DNA, it's forecasting of DNAs as well as short notice cancellations. So the intention is that we're able to forecast those patients who will cancel at short notice. Therefore, a backup booking should have already been undertaken to mitigate that. However, one of the future things that we're working on is the ability to send messages to patients who are booked into a clinic where we've seen a short notice cancellation, and see whether or not they're able to attend earlier. And that would, and we're hoping that we'll be able to automate that process. So if a patient then responds to say yes or no, then we will be able to go through and book that without kind of the admin overhead of ringing 20 patients to find one patient. That is something that's quite complex. And will take some time, but that's kind of the direction that we're heading in. So we acknowledge that things like short notice cancellations are very tricky to fill at short notice, but we are looking proactively at ways that we can help to address that, but hoping that actually those short notice cancellations have been picked up by the AI anyway. I think one of the things I mentioned in the chat, or Ben did, was that at the moment we put a cap on how many backup bookings we put into a clinic. So if one person is forecasted DNA, we won't actually backup book a clinic. It's only when it gets to 2 and above that we will backup book, and that's subject to it meeting all the other criteria. In the future, as the kind of confidence grows and the evidence builds, we will move towards going with the recommendations that the AI makes in regards to how many backup bookings we should place in a clinic. And at that point, we would expect to see quite a significant impact. So at the moment, we would already have clinics where we're seeing 25% DNA rate. And so backup booking one person is great, but it's not having the kind of the impact that we would want it to have going forward. So there are things that I think step changes that we have planned to help kind of address some of those issues.
And it probably feeds into the next question. So do last minute cancellation short notice reserve list exist? How do you choose who goes into that backfill department?
Yeah, so some of our services do actually have what some people might refer to as a hot list of patients who are available to attend at short notice, but that's not kind of standardized across the trust. And we are just about to deploy patient-led waitlist validation questionnaires. And within those questionnaires, we're asking patients if they're able to attend an appointment with less than 24, 48 hours notice. That will then allow us to generate for every service a list of patients who think that they're available sooner rather than later. And one of the things we're working on over the next 3 years with Deep Medical is a waitlist integration. So again, to look at how we can more seamlessly connect all of our data sets to help support that patient communication.
Okay, great. I know we've just hit 47 minutes, but I'm going to ask my colleague Tara. Tara, are we good to maybe stay on for another 5 minutes and go through more questions? Or
yeah, another couple of minutes. That's fine.
Okay, cool, excellent. All right, I'm going to go over to Ben, and this is very much based on how much emphasis, attention is put on the content and the message issues, i.e., the tone of voice, reading age. Do you co-design with patients? And maybe there's a further question down. You can maybe talk about some of the channels that you're currently using. So it's
great. So I'll get on top of that. So I think co-design with patients is super important. We, with Mid and South Essex, did patient and public involvement and engagement early on with sort of large groups of patients to see not only what their issues are, but also what's their understanding. And there are works at MSc around how we should be designing clinic letters, etc. All of those different features feed into the AI. So we have different ways of sending different types of messages. So we might say to one patient, if you miss your appointment, it's 160 pounds of waste, please let us know. We might say to somebody else other things about their appointment details. So the AI is trying to match that based on each patient group. SMS is one way, but as we learned with some of our sort of patient groups in ophthalmology, for example, it's really important to think about multi-channel communications. And so, in the first instance, we've been sending text messages and AI telephone calls. We're about to go live as well with newer grades of messaging, things like rich communication services, which is far closer to an app experience for patients, which they can use buttons instead of reply to words. And so, with each one of those additional iterations around channels that we're able to unlock with Webex Connect, we're anticipating even further matching and drive of engagement for patients as well.
Mark, anything to add in that at all from your side?
No, I'd just say in terms of sort of the template curation and what have you, obviously we've got 15, 20 years experience of delivering proactive comms into the NHS. So we've been able to bring a lot of the template designs that have evolved out of working with 40, 50 different NHS organisations to support some of that. But also, as Erica mentioned, they went through their various groups to get input in terms of the cadence and timeliness and content for the messages. So there's an amalgamation of lots of different sort of sources to make sure that the wording and the framing of templates was accurate and was appropriate for the different types of personas that the Deep Medical AI was generating for those who needed contact. And it is that multi-channel approach. You know, it is very much around reaching out and engaging with patients on their channel of choice. As we move forward, we hope to expand from the SMS and the voice, as you say, to RCS, but, you know, then we can start to look at, you know, other digital channels that patients want to communicate on.
Okay. Thank you, Mark. Right, we have literally now just hit 5 minutes past. So, Erica, give yourself and Tony, you know, the floor. Anything else you want to add in before we drop off? We'll take the questions. We'll get them pushed out to the panel. We'll get them answered. But Tony, Erica, anything else you want to say before we close out the webinar?
I think just really quickly, the work that we're doing really focuses on maximising the efficiency of our existing resource. I've said a few comments around, is this invest to save, etc. This is about making sure that we're using our already paid for resource in the most efficient way possible. And then if you're doing all the right things, the savings come, right? So I think that, you know, if, as Tony said, the business case ended up focusing on the additional workflow that didn't need to be done, because we were able to fill those unfilled slots. So I think it's been a really awesome journey over the last couple of years. Very, very excited about the next 3 years. And just a really big thank you to our partners and internal teams again, because it was definitely a collaborative effort. Tony.
Thanks. I'd just add, I know we've got to do everything Eric has said and others have said on this. But, you know, I'm a clinician. I do have to think about the money and those things. I know it's important. Patients at the heart of what we do. You know, we've kind of got to a place where we have accepted in the National Health Service some of the standards that we're currently offering. Maybe we've accepted waiting lists. It's unacceptable. We can't have patients. It's taking a year for me to see some patients in clinic. This allows us to change that. This allows me to see patients who've had a catheter put in and get their surgery done a lot quicker. I'm still a practicing urologist. And that's what this is about for me. This is about, sure, can we get a new digital thing get in? Can we get more efficiency? Can we make the financial? I understand all that. Quality of care and our patients are fundamental. And when that comes together with all the other things you've heard, for me, that's what makes this just a no-brainer to do, and we support it. Patients are at the heart of this. Every single patient I see improves the quality of care because I filled that extra slot. And if we did that nationally, wow, we would really transform the services we're delivering.
Thank you, Tony. Thank you, Erica. Thank you, Ben. Thank you, Mark. We will share the recording to all attendees, and we'll aim to get the questions answered timely as well. I hope everybody enjoyed it and have a great afternoon. Thank you all. Take care.